Medical school teaches you that if you have pain, there's something wrong in the body. All pain is basically structural, like 99%. But we have learned over these last few decades that there's a lot of people who actually have pain, and real pain, of course, in the absence of any tissue injury at all.
Hi, I'm Becca Kennedy.
And I'm Howard Schuvener.
And this is The Science Behind the Symptoms,
where we explore the new science of neuroplasticity through a lens of curiosity.
Awesome. It's great to see you, Howard. So this is episode 2.
Yeah, this is our second one. We're calling it How Will I Know in honor of the Whitney Houston song.
Awesome. It's the assessment. How do we make the diagnosis that there's a neuroplastic symptom or neuroplastic pain?
Right. And why is it important? Or is it important? Pretty important questions that we're going to answer.
Absolutely. All of it we'll dive into.
Okay.
So, Howard, what is neuroplastic pain and how is it different from structural-based pain? And again, I'm saying pain, but there's lots and lots of other symptoms that apply, and we're going to dive into those other symptoms in later episodes.
Right. Well, I went to medical school a long time ago, but nothing has changed. Medical school teaches you that if you have pain, there's something wrong in the body. All pain is basically structural, like 99%. But then there's like a little lecture here or there in medical school. They say, well, so-and-so might have had pain, but it was phantom limb pain. But that's rare. We never see that. That's uncommon. And
so much structural, you mean tissue damage in the body. Some sort of problem in the body.
Exactly. If there's leg pain, there must be a fracture or an infection or a tumor. If there's stomach pain, there must be a tumor or an infection or a blood supply loss.
Or a gallbladder stone
Exactly. But we have learned over these last few decades that there's a lot of people who actually have pain, and real pain, of course, in the absence of any tissue injury at all. And it turns out this is more common for chronic pain, and we'll talk about this and why we believe this, but it's more common for chronic pain than actually is structural pain. So making the distinction is huge. I mean, it's just so important.
Right. So we need to determine, like we talked in episode 1, and we'll talk more about today. Now we understand that pain is generated by the brain. So now we need to know what's the reason for it. Is there structural damage in the body as the generator? Or is it because the unconscious brain is perceiving threat in the absence of structural damage in the body?
Exactly. Is the pain due to the brain turning on pain in response to an injury to alert us that there's a problem? Or is the brain turning on pain because it has learned neural circuits of pain and it's producing them because it's a habit, basically? It's learned to do it and it just keeps doing it in the situation with chronic pain.
Yeah. So examples are, again, is what we're looking at. We're trying to distinguish, is it structural damage in the body or is it not structural? Because we now know that all pain is generated by the brain, in the brain. It's a danger signal, not a tissue injury signal necessarily. A tissue injury can be one of the reasons that the brain is interpreting the signals and deciding that we're in danger. So tissue injury, like a broken hand or a tumor or infection, can be one of the reasons for that danger signal to be made. But other reasons are neuroplastic symptoms. Our brain is perceiving signals coming in from the world as if they're dangerous. And when they do that, it then sends the signal to the body in order to warn our conscious brain so that we can respond.
Right. And it's really not that weird. It's certainly not unusual, as I said. It's not that weird. You have a stressful day and you have a headache. That's pain, right? If you're public speaking and your stomach turns into knots, that's pain. But that pain is obviously neuroplastic. In other words, it's generated by, you didn't suddenly get a disease in your stomach or your head. It's the fact that stress and emotional situations activate the same parts of the brain as does a physical injury. And so stress and emotional situations can create pain in certain areas of the body, again, as a warning signal. It's just a different kind of threat. It's an emotional threat as opposed to a physical threat that the brain is responding to. And that's the way the brain works.
Absolutely. Exactly. Well said, Howard.
Now, do you have any examples of how pain can be,
Oh, I have I have a lot of examples, even just from my own life, for sure. When I was working full time as a primary care doctor, and I had 2 young kids, and pretty much every work day at 3 p.m., I would get a headache. And from stress and tension. And I would come home and kind of relax, and I'd still have a headache before bed. It wasn't so bad. I'd wake up in the morning and I would have no headache. But as the day wore on, kind of that 3 p.m. time came around, and I would get a headache again.
And how do you listen, like low blood sugar or something like that, right? Because, that's one of the things, that's what we're doing here is we're being doctors.
Yeah.
And, we want to make sure that there's not some physical structural type of cause to account for it or to intervene. Did you try to sort that out?
Well, it was very obvious to me as a primary care doctor. Super stressed out. And we're going to go into this today. How do you figure that out? How do you figure out, is that headache that happens at 3 p.m. every day due to tension and stress, or is there some underlying medical problem? And a little bit of the information for me is, number one, I knew I was super stressed. Number two, I ate lunch every day like I always did. There was no change in that. And so my head, and the other piece is that I didn't get the headaches on the weekends.
It's the right? That's the clue. And that's so important for people to understand that what we're doing is we're playing detective, and we're just putting on our best detective hats and figure out what it is based on all the information, putting all the information together. So, and that's how we explain it to people, right? That the pain is real. It's not imaginary. It's not in their head. They're not crazy. They're not weird. And this pain, whether it's acute or chronic, has to have a reason. There is a reason. And when doctors who are trained and have the understanding that all pain is structural often run into the situation where they can't explain people's pain. Their chronic headache, chronic back pain, chronic stomach pain, chronic nausea, chronic dizziness, etc. They can't explain it because when the tests are normal, that's as far as they can go. And if they don't understand neuroplastic pain and neuroplastic symptoms, then they're going to be at a loss. And it's pretty darn frustrating for people, for patients who are suffering, when it's good that the tests are normal, that they haven't found a fracture, a tumor infection, but it's bad when they don't know what it is.
Yeah. And on top of that, what's even more problematic is as doctors, we want to help people, and we also want to know what's going on. I mean, we want to feel like we know what's going on. So, and in validating someone's symptoms, often they get that validation through giving them a diagnosis. And when we say we don't know what the reason is, often someone hears that they're not validated, or doctors just aren't used to doing that. So often what happens is we try to explain the symptoms through the body in a way to validate them, or to say, hey, this is what I think is going on. Instead of saying, doctors aren't taught very well to say, hey, I don't know. I believe you. I'm sorry, but I actually don't know what the reason is. It's just not something we're taught in medical school very well. So there's all these reasons that are given about why the symptoms are there. And so then the patient believes that there's some sort of structural problem in their body causing their symptom, even though that's not actually necessarily true. Yeah. And the teaching of doctors really primarily happens from listening to other doctors. We learn from our attendings and the people that we went to medical school that were teaching us, and it's them telling us what the information is, and it's passed down from generation and generation. So a lot of it, frankly, is not actually scientifically tested and valid. It's hard to get scientific tests for a lot of information. And people don't understand that as much.
Yeah, and there's a lot of disorders where the tests are normal, like fibromyalgia, where the tests are normal, like chronic fatigue, where the tests are normal, irritable bowel syndrome, interstitial cystitis, tension headaches, migraine headaches. Many people with nerve-like pains, the tests are normal. When the tests are normal, they're given the diagnosis, a name for the diagnosis. Oh, it's irritable bowel, it's fibromyalgia, etc. And then when it becomes chronic, they're often told that they can't get better, that there's nothing that we can do. You can take medications, you can, do a variety of things, physical therapy, medications, etc., injections maybe. But the point is that if those don't work, then they're left without understanding what's actually going on because they're not being told about neuroplastic symptoms.
Yeah. And I went to medical school a while ago, 25 years ago. And I found that actually in the past, it seemed like doctors were much more likely to say, I don't know, like irritable bowel syndrome or fibromyalgia. Hey, here's a diagnosis, and we actually don't know what causes it. We don't know what can treat it. You're going to have it forever. We'll try and help you cope with it. But I've actually found in the last 5 or 10 years that there's more and more and more new diagnoses trying to explain these things that we actually used to say was fibromyalgia or IBS. And now there's all these new diagnoses that are not scientifically valid. And as part of what we're going to dive into in this series, but people being told that they have SIBO or hypermobility as the reason, or, or molds or chronic Lyme, or, all these different reasons to explain the symptoms where it isn't actually scientifically validated. And we're going to really explore all of that.
Exactly. And it's so important because when people are told that they have something they don't, they really get on the wrong track. And it's really just a form of what I would call medical misinformation. One of the biggest areas of medical misinformation has to do with chronic neck and back pain. And we know that the reason that people get misinformed on chronic neck and back pain is because their MRI or their x-rays are showing arthritic changes, spinal stenosis changes, bulging disc changes, degenerative disc changes, spondylolisthesis changes. And what most doctors should know, but don't seem to know how to apply, is the fact that all people as they age will develop those MRI abnormalities. In other words, the absence of pain.
Mm-hmm. Right. So all people get normal degenerative changes of their joints. So all people get arthritis as we go through life.
Exactly. Just like getting gray hair. It's graying up the spine. But the research is very clear that people who have these changes don't have pain. If you went to the doctor and you said, my scalp hurts, and they said, well, you're getting gray. So, you got to dye your hair. Of course your scalp hurts. You're getting gray. You'd laugh. It's ridiculous. But that's exactly what people are being told. And we did a research study where we found of 222 people who had chronic neck and back pain, 98% of them had abnormal MRIs. So virtually everybody had abnormal MRIs, but they weren't the kind of MRI findings that were a tumor or a fracture or an infection. They were the kind of these normal abnormalities that we're talking about, bulging disc, degenerative disc, etc. And they didn't have any evidence for nerve damage when they were examined. And so in that study, we determined that 88% of them had neuroplastic pain. That's
amazing.
An amazing number because 99% of people would be diagnosed as having structural pain. And we're saying it's actually the opposite.
Yeah.
It's the opposite.
Absolutely. So this is a case where there's a test, a diagnostic test that is quote unquote abnormal, or, has some findings. And then those findings are attributed to the reason for the pain.
Exactly.
It's amazing, right? And there's another study, or study.
One of my favorite studies, right? And we're going to post that in the notes for this.
Yeah. Right.
Right. And it shows that even young people, 20-year-olds, 30-year-olds, 40-year-olds, often have degenerative disc disease, bulging disc, and these other findings in the absence of pain. And so, but this occurs in all these other areas as well, where you say, with stomach pain, well, like you say, well, we have a test showing it's leaky gut, or we have a test showing it's SIBO, etc. So,
and I want to just say one little bit about the Brzezinski study. You guys can see the name on the site. But they looked at 3,000 people with zero back pain and did MRIs of all their back and looked, and like Howard was saying, and people in their 20s and 30s, they had a significant amount of degenerative changes already at that point. But by the time that people got to be 80, 96%, nearly 100% of people had MRI findings of degenerative changes, including bulging discs and stenosis and, all of the things.
And I do myself. I've got, used to have neck pain when I was in my 30s and 40s, like you are. And, when you were, you were talking about the headache at, in that 3 p.m., in that stressful time of life. It turns out most pain occurs in that time of life. And in my life, it was neck pain, and I was getting neck pain frequently. It was coming and going. I'd wake up. It was a lot of pain. The MRI showed a lot of abnormalities. I still have those abnormalities on my MRI, but I don't have neck pain anymore. Those abnormalities were not actually the cause, although that's what my doctors thought. So how will we know? How do you know?
Let's look at that. And I also want to say I have grade 4 arthritis in my knee, and I got some pain in my knee, had some chronic pain in my knee, and now I have no pain. I ski, I run, and I have grade 4 arthritis in my knee. Yeah. So
some people will need knee surgery. Some people will need shoulder surgery, hip surgery, whatever. That's going to happen. Not all pain is neuroplastic. But if you look at chronic pain, most of it is neuroplastic, because most people with tension headaches, migraine headaches, occipital neuralgia, other types of headaches have neuroplastic pain. If you look at chronic stomach pain, chronic pelvic pain, the vast majority of people will have neuroplastic pain. The same is true of back and neck pain, as I said, and the same is true of people with chronic fatigue, dizziness, tinnitus, a bunch of other things that we'll talk about. So this is extremely common.
That's a lot.
That's a lot.
It's a lot, right? Because this is the human condition. This is just about how our survival brain was made. We detect danger, and our danger detection system was designed for the physical threat of harm. And then we developed thoughts, worries, and emotions. And that turned on the same danger detection system, sends down the signal, but we can't run away from our thoughts, and we can't get rid of our thoughts by thinking. So we have to understand that in different ways that, again, we'll talk about in later episodes.
And so how do we know? We talk to people, right? And we listen to people, and we take time listening to not only the story about the symptoms they have and the pain they have, although we put great attention on that. I was talking to a guy, an 87-year-old guy yesterday, and we were talking about his pain, and he said, no one's ever taken the time to listen to me in that. No one's ever taken the time. And so there's a few things that are clues to suggest that pain might be, or other symptoms might be, neuroplastic. And one is if people have had a number of other neuroplastic type conditions in their life. If they had stomach pain when they were a kid, if they had headaches when they were a teenager, if they had some irritable bowel when they were in their 20s, and now they're in their 30s or 40s, and now they're having back pain or something else, or widespread pain, we're saying, like, gee, these other things were neuroplastic in your life. That might be a clue that your brain knows how to do this. Your brain has done this in the past. It's not confirming anything, but
yeah.
And then we're at
so let's kind of give the overview. So in figuring out how do we diagnose a neuroplastic symptom, right? How do we know? Because there is no test to show that. So we have to look, like Howard is saying, we have to look at the pattern. And what we learn in medical school is the vast majority of diagnoses actually happen on history alone. And I don't think people realize that, but doctors make diagnoses, even doctors that don't know about neuroplastic symptoms, we actually make diagnoses all of the time. Probably 85% of the diagnosis is based on history alone. And then there's a smaller part that is confirmatory tests and the exam. So we don't have confirmatory tests. There's no test to show that this is neuroplastic. So we have to look at the pattern and the history. So first we look at circumstantial evidence that we'll go through, and then the pattern of confirmatory evidence.
Exactly.
So the circumstantial evidence, like Howard, you were saying, is prior neuroplastic symptoms.
Just to say we're doing this after the routine testing, routine workup.
Yeah.
Right. So we haven't found, we haven't found that cancer tumor infection. That's been ruled out. Right. So we do that part up front.
Right. So we first make sure we do a whole full assessment. We do whatever tests are reasonable and are needed in order to rule out that there's some structural problem to be the generator for that symptom. So it's absolutely important that that full evaluation happen and people have whatever tests that the doctor really deems are important to make sure they don't have anything else. Once
Right. And in that situation, you'll either come up with the kind of like, we don't know, we haven't found anything wrong. Or what we found wrong is not clearly and obviously damaging, like these MRI abnormalities or the mild findings that mild arthritis or whatever. That's not clearly damage, tissue injury. So then we go to the next level of the circumstantial evidence. And the first step in that is, well, what other conditions have you had in your life? Did you have stomach pain when you were a kid? Did you have headaches when you were a teenager? Did you have irritable bowel when you were in your 20s? And that can give us a clue because in people like that, we know, and people like me, people like all of us, have had these kinds of things. And it shows that our brain is capable of doing that and it's capable of doing it in us. And then we're saying like, well, what was going on?
Okay, but I just want to stop for a second and I think you're going to get to this, is what that means by being capable, because anybody's brain is capable of making these, right? But and again, we'll explore it in subsequent ones, but it's the more hypervigilance your brain has learned for lots of different reasons that we're going to cover, it's more likely then to be interpreting signals as if we're in danger. So a hypervigilant brain then can be more likely to create these chronic symptoms. So looking to your life for those.
Exactly. And when we look back, we want to know, well, gee, what was going on in your life when you were a kid, when you were having stomach pain? Were your parents getting divorced? Was there a problem in the family? Was there a problem at school? What was going on when you had headaches when you were in those teen years? What was going on in your family? What was going on with your friends? And in your 20s, what was going on in work or college?
And again, getting to those thoughts, worries, and emotions.
Yeah.
That turn on the danger signal.
Exactly. And we're looking at the wide range of areas where people have had different symptoms. Like some people may have had, well, yeah, I used to have the neck pain, and then that was this low back pain, and then it was the stomach pain. And we're just seeing a pattern there. And that doesn't confirm that this is neuroplastic, but it gives us evidence that.
Yeah. And it's all about building the evidence.
Exactly. And then what about the confirmatory evidence?
Yeah. So with the confirmatory evidence, so with the circumstantial evidence, again, it's building this case. Your tests are either normal or they don't fully explain the symptoms, or your symptoms are not responding to the treatments like you would expect. And then it's, you maybe have prior neuroplastic symptoms other times in your life. You had stress associated with those symptoms. Maybe you have a history of big stressors, of, ACEs or trauma.
Yeah.
Big trauma, maybe smaller, maybe symptoms in different parts of the body. So again, it's just gathering evidence and then building and growing the evidence. And then actually, Howard, do you want to talk about the confirmatory evidence?
Yeah. And what's great about this is we do it kind of what I would call shared discovery. So we're talking with someone and we're looking together at this evidence, looking together.
Curiosity.
Science through the lens of curiosity, knowing, understanding what neuroplastic symptoms are and seeing if they apply, seeing if they fit. So the fit criteria is something that we developed, and it has to do with FIT, functional, inconsistent, and triggered. Functional pain is pain that starts for no reason. Wake up in the middle of the night, wake up in the morning with no reason, no injury or anything. It's pain that's in a wide area of the body that doesn't fit into a pattern of a structural type problem. It's pain that spreads over time. It's pain that occurs in different places at different times. And so it's often kind of a numb or tingling, a burning kind of pain. So but
it can be any sensation, right?
Yeah.
So any sensation can be neuroplastic, but often there can be these other qualities to it, like burning, tingling, numbness, that often can be associated with the neuroplastic.
Exactly. And people aren't going to have all of these together, but they'll have a few of them. And then again, building the evidence. And it's often also pain that's symmetric. We'll start on, one thumb goes to the other thumb, or one knee to the other knee. And that's the functional, side of it. The inconsistent is just that. The pain will shift from one place to the body to another, or it turns on and turns off. Migraine is classic for that. Like your headaches, you weren't having them all the time. It wasn't that there was a damage in your brain. Something was turning them on and something was turning it off.
Yeah.
And so oftentimes people may have, their upper back hurts sometimes and then the lower back hurts, but one is turning on and one is turning off. And they're not really realizing that inconsistency, or that it goes away when they're on vacation, or that it starts right, especially Monday mornings going back to or even Sunday night, anticipating. This is common kind of findings that we see that really tell the story if you take the time, to listen.
Mm-hmm. And it doesn't always work like that. Like I had the headache sometimes on the weekends also. It wasn't just that I was enjoying myself on the weekend and didn't always have the headache. Sometimes it can roll over and, can be going on all the time. But again, looking through that pattern and really just noticing through curiosity and really thinking about what makes the most sense.
Yeah. And then there's times when it gets really bad all of a sudden. You're going along a day and all of a sudden it's way, way worse. And you can't explain it unless you think about what's going on, what was happening in your life that time. What are you anticipating? What is on your mind? What's bothering you? And if you think of it that way, then often you'll find those connections. Or you get some kind of treatment, like a massage, and it went away for a week. Say, oh, well, it was just tight muscles. But it might be that they were actually, this sounds weird, but they were massaging your brain, right? Because the brain's danger signal gets lowered by feeling safer, sometimes taking a supplement or medicine or something. Oh, I took that vitamin and everything went away for 2 weeks. So.
Yeah, which is what the placebo effect is. It's our brain interpreting information through expectation and then creating the sensation, which again, we'll dive into more. But yeah, so the fit criteria of the confirmatory evidence is looking at that pattern. And I like to compare it to a sprained ankle, because I think everybody has had a sprained ankle. So you step off the curve, you injure the tissue right then, and you have pain right then. So if you have an injury, you're not going to have pain 3 days later.
Exactly.
You're going to have the danger signal right then to protect you. And it's going to be predictable, and it's going to be only in that ankle. You're not then going to have pain in the knee, or you're not going to then have pain in the right ankle a week later, because the injury is in the left ankle.
Yep.
And it's predictable, and it gets a little better every day, more and less, while it heals. If you go out and you walk on it a mile before it's healed, the pain's going to go back up. You're irritating that injured tissue. You get back off of it, the pain goes down, and it keeps going. So it's predictable. You know the location. It's consistent with where the injury is. It's consistent with an external load, an injury that you actually knew about. But the fit criteria is when there wasn't an injury, or maybe you did something, you lifted something up, but it was like 3 days before the pain actually started. And then just like you're saying, Howard, the pain maybe starts in one spot, but then it moves to another spot and then another spot and kind of comes and goes. And sometimes I would see patients in primary care where they had symptoms all the way down the whole right side of their body. And people would even report to me, well, the right side of my body is really, it's always been problematic in my life. But there's nothing physiologic there's no nerve system, there's nothing that would connect the right side of the head, arm, and leg. It's just not our physiology or looking.
Sherlock, right. It's making those deductions and knowing how to interpret them, how to explain them to people so that they can feel reassured and happy. We know what this is. And the third one is triggered. So functional triggered is pain or other symptoms that are triggered by innocuous stimuli.
And what's an example of that?
The wind, right? So some pain can be triggered by the wind, hot, cold, weather. And there's a lot of studies on weather, and everyone knows that weather causes pain, but it turns out that the weather doesn't actually damage our body. It's learned as a conditioned response, as a trigger. Like
looking at the computer.
People with screens and computers, we've developed all these things, computer neck, computer eyes, et cetera.
Migraines, headaches.
Exactly.
The damage that were doing to any of the tissues in our body just by looking at a computer.
Yeah. Or migraines due to red wine or chocolate. It's not. And so many people have food sensitivities and stomach pain and other GI
I'm going to
symptoms
dive into all of that.
with certain foods. And so looking for that, we're looking for these triggers. And light touch is another one, for example. And so when you take together, so we have all these criteria, we've got a whole boatload of things to evaluate. And then we can put them together so we can get to the point of what I would call a click moment. A click moment where all of a sudden you realize, oh my goodness, this actually is neuroplastic. When you recognize it as the physician or the coach or the practitioner, mind-body practitioner, and the patient or the person themselves can recognize it and see it at the same time.
Yeah, right.
Have you had any click moments that you share with us?
What click moments have I had? Well, even just today, I had a patient that was seeing me because she wanted to connect up with, are the symptoms really, is there something structural that's been missed? And that's, I think, the big fear is that when doctors say, something that doesn't make sense, or I don't know why the symptoms are there, where our brain goes to is, oh my gosh, I have something rare and dangerous. The doctors don't even know about it. It's so bad. And that's where our brain goes to. And so some patients make an appointment with me and my intake form, I have them, just list out everything that's happened in their body and throughout their life, as well as then in their life with stresses. And oftentimes just filling that out is that click moment that they look at the pattern and say, oh my gosh, look at this pattern over time of the symptoms correlating with what's been going on in my life.
Yeah. Yeah. I had a person who emailed me, a doctor, and he's happy to share his story. And he had this back and leg pain that certainly seemed structural. He had an MRI abnormality, which a large enough bulging disc that looked like it was causing that pain in his leg. It was in the right area for the pain. The pain wasn't coming and going. It wasn't triggered by innocuous stimuli. And he's like, well, how do I know? And, I said, well, let's be Sherlock. Let's try to figure it out. And it might take some time. And this took several weeks for us to figure it out because he kept looking over time for any kind of inconsistency, any kind of trigger point to it, because he had all sorts of physical therapy, injections. He was looking at surgery. He didn't have any abnormalities on his physical exam to prove that there was actually something structurally wrong, but he was worried about it. And it was unclear. And it was unclear to me. So I said, keep looking, keep looking. And one day, he was walking up the stairs and he recognized that when he walked upstairs, he didn't have this back and leg pain. But he was walking up the stairs with a cup of tea in his hand. And then he had it. And he's like, well, wait a minute. How can that be? What is the difference walking up the stairs with a cup of tea or not? The cup of tea doesn't weigh that much. It's not putting any pressure on my back or my disc. And then he said, well, there's a reason for it. So it must be tension. So there's tension in my arm. And where's this tension coming from? And my brain is tense, trying to not spill the tea. And then he said, oh my God, that was his click moment. It was my brain worried about the tea causing tension, but the tension was transmitted to my back and leg. And he got better. He got completely better after that because then he knew he could start moving without fear. He could start watching his sensations, do all the treatment things that we're going to talk about in the series. He started doing them. And within a few months, he was fine. And then he said, I've got this trip coming up to Europe and I've got this big suitcases to carry. And he said, you know what? I'm going to do it. And he did. And he was fine. He back to playing tennis. And, and this is an older man, he's in his late 60s or early 70s. He was worried that it was old age and he would never get better.
Yeah.
And he did. So that click moment, I think, was just so critical. And the only way we found that click moment was by taking the time and investigating, keeping looking for it's functional, is it inconsistent, is it trigger? This was trigger. And that was amazing story.
That is amazing. Yeah, actually, I have a patient just recently who's had back pain on and off for 20 years, told it was spondylolisthesis at one point, and he went on a 75-mile bike ride with zero pain.
Wow.
and then got pain, a couple days later or a week later or whatnot, and still was, concerned that it was structural damage in the body. And again, I keep coming back to that with him and saying, there's no way that you can bike 75 miles with zero pain and actually have structural damage in your back.
Yeah. And like a couple others, I had a patient who had eczema. And eczema, you think, well, that must be an allergic condition. That must be a structural issue, allergies, et cetera. But she'd had it many, many years, and it would come and go, come and go. And she told me she had a really severe episode of it a few years ago. And she got a couple acupuncture treatments. It totally went away. And I said, well, I think that tells us a lot, because acupuncture is working on the brain. Acupuncture is a really good treatment, and a placebo treatment. We can talk about that, but want to look at the data. And we said, we got it. And then she was confident that these mind-body therapies would be effective, and they were. So that was, and I had another guy who had asthma, and we were thinking, well, asthma must be inflammatory, must be structural, et cetera. But he's like, wait a minute, I'm in the car and I'm going to work and I'm having trouble breathing. I need my inhaler. And then I'm walking outside, on a beautiful day, and I'm having no asthma at all. What's going on? And then that was his click moment where he realized, well, wait a minute, I can get better. And he's now off almost all his, and he had severe asthma, for many years. So
yeah,
it's really just the whole thing, to get the whole story, to put it all together and make our decision. Can it be both? Can it be,
yeah.
you
Can it be both? Right. And of course it can, right? Because we also do get structural damage in our body, and we can have a hypervigilant response to that damage also. And, so there can be a huge big signal, or the signal continues after the damage. And again, looking at the thick criteria to try and figure out how much of it might be neuroplastic, how much of it is damage in the body. And actually, one thing that I do that I found is helpful is I actually flip it around when I'm not quite sure. And for instance, I developed chronic pain in my knee where I had my ACL replaced a couple times. I have arthritis in my knee now. And I kept sort of thinking, well, there's the pain there. Is this neuroplastic? Is this the arthritis? Is it damage in there? And then I thought, okay, pain is a warning signal, so I don't injure myself. So if it's my knee, if say there's damage in my knee, if I don't heed the warning signal of pain and I keep walking on it, and I could damage that tissue injury even more, it can't heal. So then I would think about, well, if I have this danger signal, if I keep going through, if I keep pushing through the danger for the pain, for instance, what damage would I then be causing to my body? Like, what would be happening in my body that I needed to attend to that's going to create more problems? So for me, when I had chronic pain, my leg would be straightened out, and all I would do was tighten my thigh muscle. Like, I didn't even move my joint. All I was doing was flexing my muscle, and my knee would hurt.
Right.
Just from flexing my muscle. So again, actually, that was an aha moment. That's evidence. Not even moving the joint, I couldn't possibly be actually harming any tissues in there.
Yeah.
So it, must be neuroplastic.
Right, because the brain will tell you, if you look closely enough and you look for the clues, the brain will tell you. It'll give you those clues. I had a situation where I had pain in my Achilles heel, and I had injured it. And I talked to my brother's an orthopedic surgeon. He said, this is structural, Howard. This is not mind-body. He said, you think everything is mind-body? And I said, no, I don't. But he said, fine, this is structural. I said, okay, fine. He said, do your exercises. So I'm a doctor. Did I do the exercises? No, of course not. Well, whatever. I figured it would heal, right? So I just kept going. I kept exercising. It hurt some. I wore a heel lift, whatever. It was kind of getting a little better, but it just kept dragging on, another 6 weeks, and then 2 months and 2.5 months, it was still hurting. And my brother's saying, well, it should have been healed by now. And I'm thinking, yeah, it should have been healed by now. Why is it still hurting? So I think it was a structural injury. But then one day I was walking on it. I was in a hurry. I was being rushed. It was a stressful situation. I took one step. I got this huge jolt of pain in my heel. And then I thought, wow, did I twist it? What did I do? And then I realized that was just a normal step. It was a normal step. I hadn't done anything structurally. I got a huge increase in pain. And when that happened, that was my interpretation. That was my brain saying, hey, it's neuroplastic, buddy.
Yeah.
And then I realized it had started out as a structural problem, but now it wasn't structural anymore because it had healed. And then I started to get better, and then I was fine within a few weeks. So that was a great moment for me with that one.
Yeah, amazing. Because that danger signal can be stuck in place after the body heals. And the brain now learns to be hypervigilant and be protecting of that part of the body that we don't need anymore.
And that shows how important it is to distinguish between neuroplastic pain, structural pain, or a combination of the two.
Yeah.
And as we said, the vast majority of people with chronic pain and other chronic symptoms, more significant and severe medical problems that have been rolled out, the vast majority of folks actually have neuroplastic pain. And it's rare to find that it's structural after the normal routine tests have been ruled out. And it's usually not a combination. It's usually neuroplastic pain, which means, and we have means for diagnosing that. We know how to do it. How do we know? We can figure that out if we take the time.
Yeah, absolutely. Yeah.
And the difference in the treatment is mammoth, right? The difference between doing some structural thing that, injections, physical therapy, medications, et cetera, which make people feel more like I'm damaged, I'm broken, and then it doesn't work. They get discouraged versus changing the mindset to say, when it's neuroplastic, you can recover.
Yeah.
That is you can recover, and you can recover fully. This is amazing. And we have techniques to do that. And these techniques have been shown and proven in randomized controlled studies that they work.
Yeah. And we will go into those techniques in subsequent episodes. Yeah. Exactly.
And it all stems from figuring out, is it structural or not?
Right. Because as physicians, we need to make the proper diagnosis, right? We can't treat a sore throat. And if it's a virus versus strep, we need to know that so we can give the proper treatment. So now that we know about neuroplastic symptoms, that is one of the diagnoses that's the possibility for actually really any symptom in the body. And so we need to include that as a possibility so we can make the correct diagnosis so then someone can get the correct treatment so they can get better.
And, just to say that it's actually not that difficult the vast majority of the time. It's actually pretty easy. And these criteria we're going to put on our website at the ATNS, symptomatic.me, and they're in our books. And most people who have their own pains can figure it out if they look at if they understand how the brain works and they look at the criteria. They can figure it out at least 90% of the time, I think. And that is, it's amazing. It's not that complicated.
And I want to say, when I first learned about this and I heard you, Howard, say, the body heals, our body heals. And I had this existential moment and I thought, wait a minute, what is structural damage of the body? What are the choices here? And there are frankly not that many. I mean, if you think about the tissues, there's damage to our muscles, tendons, and ligaments and bones, right? That can be torn and broken. And then there's our organs, the things that can happen in our organs, gallbladder, appendicitis, infection in our skin, a tumor, some sort of damage to the major nerves that are actually physically damaged, something metabolic, diabetes, anemia. There can be a problem with our brain, again, a tumor, some sort of damage in our brain, an aneurysm, a stroke. Did I miss any major category? I mean, that's kind of a major category.
Yeah, there's some genetic disorders.
Right? There's some genetic disorders, but actually genetic disorders are exceedingly rare.
Yes.
Exceedingly rare.
Exactly.
Mm-hmm.
And so what we're doing is we're helping to teach other doctors, other counselors, therapists, and the world at large about this work. And most doctors haven't learned it yet. Most doctors aren't going to know about it. And so you can't actually expect most physicians, your physician, to say, okay, well, oh yeah, this is obviously neuroplastic. You can use your doctor to help rule out the significant structural problem. And then you use our criteria and our information, rule in a neuroplastic problem. And once you've done that, it opens the door to to health and well-being.
And this is such an important point, Howard, because the vast majority of people do not know this. Doctors, specialists, people at major institutions, naturopaths, functional doctors, physical therapists, acupuncturists, they do not know this. And again, so what the natural human thing to do is to find a reason to explain the symptoms. And when people are looking in the body, it's very, very likely that they are going to say something. They're going to find some reason to explain the symptoms that's body-based. But when it's a neuroplastic symptom, that's not correct. And there's vast majority of that time, there is not actually scientific data to prove that what people are saying is the actual reason for the symptoms. And again, that is what we're going to really take a deep dive into, is what makes sense and what does the science show? Like, how do we put all of these pieces together? Because that's really critical.
Right. So how are we going to fix this? We're going to get everyone to listen to us. Well, maybe not. What we are doing the science. We're writing about the science. We're doing the studies. We're getting people better. People who get better go back to their doctors. They tell them about it. Some of the doctors are interested. The research is coming out. More and more studies are being produced. And over time, there'll be a tipping point, because what's happening now in the field of chronic pain is it's not working. We don't have simple and effective treatments for most people with chronic pain. So this is the future. This is a revolution in healthcare. And we're doing it basically through, exploring neuroplastic symptoms. Right?
And exploring the science. And through curiosity, again, to gather evidence and really look at what makes sense. How do we take all of the pieces of information and put them together in a way that actually makes sense? And hopefully, as you listen to this series over time, you'll start learning more and more pieces of information that you can use to put together in a way that makes sense for you.
This is the ATNS podcast. I'm Howard Schubiner.
And I'm Becca Kennedy.
And thanks for being with us. See you next time.
Looking forward to it.